I'll not be taking much time and we'll be starting right away. I'll invite our keynote speaker, Dr. Ita Levy, for his keynote address. Dr. Ita Levy is from Hetsa Medical Center, Department of Ophthalmology, Jerusalem. He is a corneal surgeon, and he's one of the leading DMEK surgeons of the country. And he has been doing work on basically converting from DSEK to DMEK and getting the best of results. So I introduce to you Dr. Ita Levy, please.
Thank you very much. It's a pleasure to be here. So I'm from Hadassah, and can I get presenter view? Somehow? Can I get the presenter view? Which one? Alt F5. Just press twice. So I would like to present our work in challenging DMEK cases, or in other words, the war on the compromised anterior chamber. So which are those cases? We categorized the challenging DMEK cases, and these factors were the most influential on the surgery difficulty. The anterior chamber IOLs, of course, vitrectomized eyes, large iris defects, tubes and traps, synechia, aphakic eyes, and post-PKP patients. And what you can see here is two corneas, two eyes with DMEK after PKP, and they are completely different. So what we are doing right now, we are doing anterior chamber OCT before every surgery, and we estimate and we evaluate those corneas before we do the surgery. So you can see the posterior surface of the cornea here in the left picture, which is the bumps there will cause the detachment, 100% detachment. So you will have to rebubble it, then you will lose endothelial cells. And in the other case, which is also after PKP, the surface is smooth, so you can use a large. So what we can see with preoperative OCT, A is, you can see the anterior synechia. B, the interface between the PK graft and the host where the most of the detachment happens. C is how we're sizing the DMEK graft. We're not using the whole cornea. So we used to do like a slit lamp examination, measure the cornea, or use the size that the previous PKP done, but the actual size that needs to be done is the one which has the same slope, the posterior slope. So this is how we sizing our DMEK grafts now, and we get about less than 15% of detachment rate after PKP, which is even acceptable for normal eyes. D is the position of the lens. It's very important because sometimes when the lens is tilted, because you get those referrals and you don't know what's going on there, sometimes you can get vitreous, and vitreous will kill your DMEKs for sure. And E is a very edematous, and if you see those clefts over there, that means that they have no decimate membrane, which means that DMEK will probably not be the best case here, and in this case you may do a PKP or even a DSEK. So we start with anterior chamber IOL. And the first thing we have to decide if this eye is eligible for EK, for endothelial keratoplasty. And how do we decide that? We measure the distance with anterior segment OCT between the posterior cornea and the anterior part of the optic of the lens, which is the real ACD that we are going to use. If it's less than 3 millimeters, then this eye, you need to move the lens backwards. You need to exchange the lens. If this more than 3 millimeters or more, there is no difference between primary DMEK on this eye and not doing anything else instead of the DMEK. So what can be the problem here? The IOL can be dislocated. The anterior chamber lens, they are not always sitting right. And when this lens is dislocated, many things can happen. First of all, the DMEK graft can go right straight to the macula because these eyes are most of the time vitrectomized, sometimes with full vitrectomy. And second thing is the DMEK can be entangled in those haptics there, and it is really hard to move it from there. So what we are doing is we are stabilizing the anterior chamber lens, and we are suturing one of the haptics to the iris, which first gives us a lot of space to work on. It actually makes the ACD bigger, and then we have more depth, and the prognosis of the DMEK graft is better after that. But the main problem with the anterior chamber IOL is that how do you manipulate your DMEK graft? Because if you manipulate it on the bottom of the chamber, you will lose a lot of endothelial cells because you're going to do it on a plastic or, acrylic material. So let's think what we are going to do. And what we are doing is that we developed a method which is called the DMEK wave maneuver. And the principle is quite simple. We insert the graft, hopefully in good orientation, and if not, we move it to good orientation, locking the graft in the angle, and after that, we elevate the graft with a small air bubble. And like the bubble bumping maneuver, if you know what it means, we just give, we use the fluid currents between the graft and the posterior corneal surface to move the graft in the desired direction, and the tapping is made on the corneal surface. And the friction area is between the decimane and the posterior cornea, not between the endothelium and the anterior chamber lens, which means that we can actually work on the posterior corneal surface without harming the endothelial cells. And this is a demonstration of how we are doing it. Yes. So, injecting the graft. After injecting the graft, we are not pushing it so much, just to a little bit open it and sticking it to the angle. After that, small air bubble behind the graft or below the graft. Here we get more than one bubble, but this is fine. They should be small, not very, and they should be under the graft. So right now, this is one of our first cases. You see we're trying to get the bubble below the graft so it can move. And if it cannot be moved, then we're just moving the eye. And then when you get the air bubble, see how the DMEK graft is moving toward the desired location that we want it to move. And this is how we center it. So we lock it in the angle and then move it. Here we get the pupillary block. This is my fellow doing the surgery. And what I did is just took out the air, left a little bit of air there, and see how easily the graft is moved on the posterior corneal surface. And this is another example, and we're going to see it in a different movie, so I'm going to show it later. Sometimes we have to remove the lens. In cases of, we get a lot of these cases from Russia. This is a Sputnik lens, which has haptics that are protruding to the anterior chamber. And here we have to replace the lens because you cannot deal with DMEK grafts on this kind of lenses. So, so I guess this is pretty much a standard surgery. Sorry. And I think we can, we just remove the lens and doing like a normal DMEK. There is nothing here too much. We are using maintainers in all of these cases where we have compromised capsule or vitrectomized eye, so I'm going to see why. So in vitrectomized eye, we have to distinguish first between core vitrectomy and full vitrectomy, because core vitrectomy sometimes behaves like a normal eye and you don't have to do anything else. But with full vitrectomy, you have to give support. So the problem, one of the problems is lack of support from the posterior part of the eye, and the graft is too mobile in the eye, so it's really hard to open those grafts. So what do? First, enlarge the grafts. We're doing large grafts from limbus to limbus, and then it can be easily maneuvered inside the anterior chamber. And of course, posterior maintainer, which we are using it in all of our surgeries. And here you can see one of our horrible mistakes. See what's going on here? So you inject the DMEK graft, and it's on the macula. It's not where it's supposed to be. So what was the problem there? The problem there was that the maintainer was closed, and when we inject the graft, we have to move beyond the pupil. You cannot inject the graft over the pupil in a vitrectomized eye. This eye, we did IOL fixation before, and you have a gap between, you always have a gap between the iris and the IOL. And what we did is we pulled out the DMEK graft, and we used the same graft, but you see we're doing it on the posterior corneal surface with a small air bubble. It can be maneuvered and positioned, and look, and the graft is not touching the bottom of the anterior chamber, and this patient is doing quite well. And the last thing I'm going to talk about is, not the last thing, but the last thing I'm going to talk about is DMEK on PKP, and you see how our keratoplasty is. This is the trends that we have, that we had in the last 50 years, and you can see here in the last years, it moves towards graft failure. Because we have more graft failures, the indication is graft failure more than anything else. So we are doing a lot of DMEKs on PKP because those grafts, you know, they have a limited life. They have a limited time that they can work, usually 20 years, 15 years. And we are doing a lot of them. So the common conclusions from DMEK on PKP is that we have higher rebubbling rates, higher ECD loss. It's technically demanding. It's not like primary DMEK, and the glaucoma surgery, because they sometimes have glaucoma surgeries, is very bad prognosis for the graft. So, of course, measurement, preoperative measurement. What we are doing is our technique is doing the subtenon triamcinolone when we are doing the anesthesia. This is, we get a depot of steroids, and we get less CMEs after those surgeries. We are doing the incision not inside the interface, just on the host. We are removing membranes if we can. If you have this kind of scarring behind in the posterior surface of the cornea, we just remove them. And we end surgery with SF6, 20%, but 100% of the chamber. And this is a demonstration of the surgery. So we're doing triamcinolone. We are doing the paracentesis in the host. And the way to do decimetorexis is to just pull, okay, the decimate, like here, like you're doing rexis in a cataract surgery. We're not scoring before that, so we're removing all the posterior scarring. And this is just like a normal DMEK surgery. Montsuri sign. And here is another demonstration of the DMEK wave maneuver. The bubble should be a little bit smaller, and the graft is freely moving on the posterior surface of the cornea. And this is how we end the surgery. And in cases where we have a very opaque cornea, well, you need the money for that, but we have now anterior chamber OCT, and as you can see, this is quite helpful because you cannot see anything during surgery, but you can really see the position of the graft, and it really makes our life easier when we are doing that. So the conclusions are that a DMEK wave maneuver can be very helpful in advanced DMEK cases, especially in those cases where you have compromised anterior chamber. Explain the patient that the rebubble is part of the procedure. We need to compare DMEK to DSEK in challenging cases, and we are doing it right now. And of course, we have to consider to take out the lens and replace it when we have anterior chamber lens, and do we have more benefit in posterior chamber IOL. So, thank you very much. It was a pleasure being here.
Thank you. It was a really eye-opener for us, and it was really a very good eye-opener lecture for us. Thanks a lot. DMEK will definitely be changing the times to come, and I think it will be much better than the results that we get with DSEK. And anything else you'd like to add, Dr. Levy?
No, the trend is now moving from DSEK to DMEK in all cases because, visual acuity after a few months is much better than with DMEK than in DSEK because we don't have those interface. Also, when you use DSEK on anterior chamber IOLs, remember that you are going to make the ACD smaller because the DSEK has some, volume in it, and it has some thickness. So you're making it smaller, the endothelium is closer to the anterior chamber lens, and then you lose more endothelial cells. Actually, when we have to do DSEK today, we're doing PDEK because this is, you get like this really small but rigid grafts, and they are easier to handle than a normal DMEK graft, but the surgery is like DSEK. You can pull it and just, maneuver it like a DSEK graft, which is the major advantage of DSEK over DMEK, because DMEK is sometimes very technically demanding, and you need to see what you're doing.
Thank you.
Thank you.
Now we will be starting our IC. So we'll be talking today on keratorefractive surgery changing scenarios. I am Dr. Neeraj Khunger. I am the chief instructor. We have Dr. L.K. Nepalia with us, who will be talking on past, present and future of keratorefractive surgery. And Dr. Arun Kshetrapal will be talking on PRK revisited. I'll be talking on newer paradigms in proper case selection. And Dr. D.D. Verma from Kota will be speaking on scope of conventional LASIK in today's scenario. And Dr. Virender Agarwal from Jaipur will speak on does smile always give a smile. And then we'll have a tailored approach for individual patients. So last 3 decades have witnessed phenomenal changes in this subject. We'll be covering past, present and future in keratorefractive surgery with newer paradigms in case selection and tailored approach for a given case to get the best outcomes. So maximizing the outcome in different available techniques will be video based. So now I invite upon Dr. L.K. Nepalia.
Thank you, Dr. Neeraj, for giving me an opportunity to share my talk in this instruction course. I shall be highlighting about past, present, and future of keratorefractive surgery. I have no financial disclosure for this talk. As you all know, keratomyeliosis surgery is a surgery in which refractive disorders are corrected by reshaping an inner layer of cornea, which was formerly performed by freezing corneal layers and forming them to a new curvature, but now usually performed using a laser. The corneal procedures in use in past were thermokeratoplasty, keratotomies, epikeratoplasty, laser ablation, conductive keratoplasty. Some of the other intraocular procedures used for correcting the refractive error included clear lens extraction, lens exchange, ICL. Now, history goes back to 1962 when Barraker invented a keratome with suction rings. Then in the 80s, PKS technique to perform non-freeze refractive cut was there. In late 80s, Ruiz developed automated keratome. A precursor to modern refractive lenticle extraction, that is RELEX, was first described in 96 using a picosecond laser to generate an intrastromal lenticule that was removed manually after lifting the flap. However, significant manual dissection was required, leading to an irregular surface. An Indian engineer, S. Srinivasan, is to be credited for understanding the properties of excimer laser. The 193 nm argon fluoride laser used for photoablation to create a new radius of curvature in the corneal stroma. In 83, Proket, a scientist from Columbia University, along with our own Srinivasan, performed the first PRK in Germany. Charles developed a formula to develop the amount of tissue removal necessary to reshape the cornea to induce a change in the corneal refraction. He designed the first excimer laser intended to reshape the cornea. In 88, first application of PRK was performed by McDonald and Kaufman. So this is how the evolution has taken place. RK, AK by Fedorov, then PRK by Trokel, LASIK by Pelikaris, then LASEK by Talamo et al., then intra-LASIK by Kurtz, and EPILASIK by Pelikaris. The procedures developed from past to present in chronological order included PRK, LASIK, LASIK and EPILASIK, tracker technology, customized LASIK, optimized LASIK, femtosecond laser flap, topo-guided laser treatment, RELEX, SMILE, and LASIK XTRA. PRK is a procedure where the corneal epithelium is removed and discarded, allowing the cells to regenerate after the surgery. PRK permanently changes the shape of the central cornea using an excimer laser to ablate a small amount of tissue from the corneal stroma just under the removed corneal epithelium. First PRK was performed in 87 by Saylor. PRK has certain advantages that it is working very good in myopia and astigmatism. It's a very stable procedure, but it is associated with some disadvantages like postoperative pain, delayed healing, and scarring. Then in LASIK, that is laser-assisted in situ keratomiliosis, the anterior flap is created with a microkeratome hinged, and on stromal-based bed, laser energy is delivered to ablate the tissue, and then flap is reposited. Wow factor, patient gets good vision instantaneously and is very happy on day one. You can see a small video clip. LASIK has advantages like very rapid recovery, decreased risk of scarring compared to PRK, no pain, but some disadvantages it has got are flapped stria, you can see on your screen, buttonholing, partial flaps, debris, epithelial ingrowths, DLK, late trauma, ectasia. LASEK and EPILASIK. LASEK is LASEK, the epithelium removed with alcohol, you can see the video, to get complete epithelial removal, and then laser ablation is done. A contact lens is applied, which is removed 3 to 5 days after the surgery.
To carry out no-touch or laser surface ablation.
In EPILASIK, the epithelial flap made with keratome and photoablation done, the epithelium flap is reposited, but usually epithelium is lost over the time. We remove epithelium by manual removal or by a brush technique or by laser scrape or alcohol assisted. Epithelium removed in PTK mode followed by PRK, but it's difficult to determine exact depth and there may be little overcorrection also. In laser scrape, the epithelium is removed partially. More popular is epithelium removed in dim light and stopped as soon as the color of the laser changes. Remaining epithelium is removed with spares. You can see EPD LASIK keratome. With all these previous machines, a lot of decentered ablations were noticed with induction of HOAS. Then newer machine came with trackers so that in case of fixation loss, machine tracked the pupil up to a certain extent and got instantaneously shut it beyond tracking. It helped in much better pupil centering with accurate ablation and improved outcomes. Customized and optimized LASIK, custom LASIK, wavefront guided LASIK. Unlike conventional LASIK, which is based solely on refractive factors, custom or wavelength guided LASIK is based on the total aberration of the eye. A wavefront map is obtained prior to surgery, which is used to program a custom treatment. Iris pattern is captured and is transferred to LASIK machine, thus taking care of cyclotorsion, thereby increasing accuracy in higher astigmatism. Although the goal of wavelength LASIK is to correct HOAS, the procedure actually makes them worse than before surgery. Though the increase of HOS is greater with conventional LASIK than with custom wavefront guided LASIK. It is due to removal of more tissues in periphery of the cornea to account for the loss of laser energy on the slope of the cornea, that is cause and effect. The wavelength optimized LASIK attempts to maintain the cornea's original curvature shape by applying more laser energy in the periphery, but like other forms of LASIK, it consistently leads to an increase in higher order aberrations. From the FDA website, it has been downloaded, and it says that although wavefront guided treatments attempt to eliminate higher order aberrations, results from the clinical studies have shown that average aberrations still increase, but less than they do after conventional LASIK. HOA are present in all human eyes, but in normal, unoperated eyes, HOAs are so minor that they are barely noticeable. The cutting of a LASIK flap and ablation of corneal tissue creates an unnatural, irregular shape of the cornea, which increases the higher order aberration of the eye. That's what the website says. Then came the femtosecond era. In this, the laser technology uses near-infrared radiation from neodymium to cause photo disruption. When it interacts with tissue, it causes plasma formation. This plasma of free electrons and ionized molecules expands rapidly to cause cavitation bubbles and separate the tissue. It gets its name from the speed of which light is delivered. Till date, flaps created with a mechanical microtome were associated with complications such as free caps, buttonholes, stria, central islands, and refraction. Then came the newer tool in the form of femtosecond laser for making corneal flaps. The use of femtosecond laser has led to a significant decrease in these types of complications. The precision and speed of the laser have virtually eliminated irregular cuts, overly thick flaps, and trauma induced by manipulation. The laser's speed is a major contribution to safety and patient satisfaction. The diameter, the bevel shape, and the thickness of the flap are present according to surgeon's plan for the individual patient. Customizing side cut angles create a more biomechanically stable corneal flap. Creating an inverted B-level side cut, that is reverse side cut at 150 degree, increases the flap's stability. This architecture permits to tuck the flap. Thickness of the flap can be adjusted as per residual stromal bed required. Creating the LASIK flap takes around 10 seconds per eye. Safer flaps. In femto, the advantages, the flap is thinner. There are very few incomplete flaps or buttonholing, but there are some associated disadvantages like persistent photophobia, rainbow factor, higher DLK, late traumas, and ectasia. Indications for topographic guided laser surgery are where complications from refractive surgery, you get patients post-keratoplasty, astigmatism, and highly irregular astigmatism. Expanding the optical zone and correcting decentered ablations or after previous RK, astigmatism after keratoplasty. Topography guided platforms use a Placido disc, Schillflug photography, or a combination of both methods to capture images which the system analyzes to correct corneal shape via properly logarithms in shape will cause a change in power which previously required to a second refractive laser treatment if there were sufficient tissues. This you can see from topography, the data is transferred to the machine, and then that is how it is being done after doing a proper corneal topography. Laser corneal refractive surgery procedures based on extraction of an intrasomal stromal lenticule. RELEX can be performed only with the Visuaz Max laser, which is capable of intrastromal cutting in 3-dimensional from the corneal surface. In this procedure, a lenticule, a disc of corneal stromal tissue, is cut with micron scale precision by the laser, and the refractive error is corrected when the surgeon dissects the remaining bridges of the corneal tissue and removes the lenticule. Lenticule shape and size are based on mathematical calculations for correcting a specific refractive error. As most of the complications in LASIK are flap related, newer techniques came up to get rid of these problems. RELEX, when performed through a small incision, is described as a small incision lenticule extraction SMILE. SMILE was first performed by Secundo in 2008 using two opposing 5.0 millimeter entry incisions at 12 o'clock and 6 o'clock. SMILE, one intrasomal keratomycosis technique that requires a single femtosecond laser to create a three-dimensional lenticule that is extracted through a small corneal incision. It circumvents creation of a corneal flap, and there is preservation of the anterior-most stromal lamella and bombus layer, excluding the region of the incision. That is how it works. You can see the lenticule cut 1, lenticule side cut 2, the cap cut 3, and the cap opening incision at number 4. The Contura Vision, the topographic guided LASIK, it treats corneal aberrations rather than wavefront aberrations. Best candidate for Contura Vision are those who are having irregularities on corneal topography, which are reproducible at least 4 to 8 per eyes, and accurate with no significant excess difference in manual refraction and topo results. The custom treatment uses a variety of extremely detailed images on eyes to assess a patient's specific vision correction need. The patient's eye is imaged and analyzed using 22,000 unique evaluation points on the cornea. This data is then sent to a surgical planning computer to create an individualized custom profile to optimize the patient's vision. The LASIK XTRA, the LASIK is in combination with CXL, that is LASIK XTRA, is an alternative to traditional LASIK aimed to restoring the strength of the cornea, increasing stability in visual outcomes, increasing the accuracy of the refractive correction, and potentially lowering enhancement rates. The procedure is frequently performed on patients who are considered good candidates for the LASIK procedures, but may fall into categories associated with a greater risk of post-LASIK regression, those with hyperopia, with high amounts of myopia, younger patients, and those with borderline predicted residual stromal bed thickness and suspect keratoconus. Stiffening of cornea, which has been structurally weakened by LASIK through the addition of CXL, may minimize the negative effects associated with this biomechanical compromise. Although not yet approved by US, the LASIK XTRA is in clinical use in more than 50 countries worldwide. The creation of the LASIK flap and the excimer ablation are performed in the usual manner. However, many surgeons adjust their treatment algorithm to account for reduction or elimination of regression, typically seen in LASIK and photorefractive procedures. LASIK XTRA is performed immediately following the excimer ablation because the LASIK flap no longer contributes to the biomechanical strength of the cornea. The region of stroma targeted for a CXL is the area directly beneath the ablation zone. At the completion of the excimer ablation, eyes receive 1 to 5 drops of dextran-free riboflavin formulation applied to the stromal bed, avoiding application to the LASIK flap. The riboflavin solution is allowed to soak for a period of up to 90 seconds, after which the riboflavin is rinsed from the stroma using BSS. Once the LASIK flap is repositioned into place and the flap is interface copiously irrigated and stroked into place. A 375 nm UV source with a homogeneous 30 MW CM top head beam profile is then used to apply a 2.7 dose to the irradiation through closed flap. Smart surface ablation is touchless, no solution, no suction, no flap, no incision. It is safe, high corneal stability. It is fast treatment in one step. It's short healing process with fast reduction of the epithelium. Smart surface trans-PRK is a touch-free laser eye correction method used with Schwindt's Emirates laser system. The future of keratoplasty surgery, we have to address the problem faced now. There may be a topography-guided treatment in smile. I think Dr. Virendra Agarwal, who is a great smile surgeon from Rajasthan, would highlight about this. The woe factor in smile, the hypermetropia, which is a limitation in terms of treatment in smile. Newer softwares to treat anticipated induced HOA after LASIK, along with topo-guided and wavefront aberrations with the help of data collection of induced HOA and using data mining for this to decrease post-op dryness. Intraoperative abnormality may come up to get rid of flap-induced aberrations. We need better trackers and finer laser beams and less heat generation at the cornea. So these are some of the procedures in pipeline, and we hope will come out with more and more better photorefractive surgeries in due course of time. Thank you, ladies and gentlemen, for your kind attention. From that part of the vehicle, we want to come to the other part of vehicle with these future procedures in mind. Thank you once again. And thanks to Dr. Khunger once again.
Thank you, Dr. Nepalia, for your exhaustive talk. I think he has covered everything in refractive surgery that has been there. And now I'll be talking on newer paradigms in case selection. There is no financial disclosure. So I'll be covering this topic under general criteria, systemic criteria, ocular criteria, occupational criteria, and criteria for the newer modalities of keratorefractive surgery: smile, contour vision, topo-guided treatment, smart surface ablation, and LASIK XTRA. And I'll also be just talking about the financial parts. In general criteria, we usually take age 20 years and above for girls, for boys 21 years. Refraction should be stable for 6 months, and the variation should not be more than 0.5 diopter spherical equivalent in last 1 year, and no contact lens wear for at least 7 to 10 days. I take it as 10 days, some of the surgeons take it as 7 days. Coming to relative contraindications: diabetes, collagen vascular disease, autoimmune diseases, history of colloid formation, as these can lead to unpredictable results. Previous history of herpes simplex or herpes zoster, pregnant or nursing woman for 6 months because of change in corneal hydration and refraction, patients on hormonal replacement therapy or systemic steroids, as this may interfere in healing. Myopia maximum up to -12, but with the advent of ICL, this value preferably has gone down to -8 with strict adherence to corneal thickness and residual stromal bed requisites. I'll be covering it in the next slides. Hypermetropia up to 8, but preferably up to 4 diopters, astigmatism -6 diopters, and rule out any other ocular pathologies. Ocular criteria: absolute contraindications are refractive instability, ectatic corneal disease, thin corneas less than 490 microns for LASIK and less than 470 microns for PRK. Residual stromal bed after ablation in LASIK should not be less than 280, but nowadays it is going to 300 microns or 55% of the total minimal corneal thickness, whichever is more. So total residual corneal thickness not less than 80% of the minimum preoperative corneal thickness. So if preoperative is 500, the postoperative should not be less than 400. Presence of any active corneal pathology, SJ syndrome. LASIK is also contraindicated in moderate to severe glaucoma, as contrast sensitivity is already compromised and further gets worsened with keratorefractive surgery, as when suction ring is applied, IOP rises up to 60-65 millimeters in microkeratom, which can be detrimental to the optic nerve head. So relative contraindications: blepharophimosis, corneal neovascularization, monocular patients, dry eyes, sunken eyes, mesopic pupils larger than the optic zone. This is also very important when we take a patient for a refractive surgery. Retinal vascular disorders: if there is any retina hole, we have to first get it treated, wait for at least 15 to 21 days. Nowadays it should be at least 3 weeks. lenticular opacities. We should not do LASIK in those patients. So apart from thickness, corneal power, flat or steep, we have to see PENTACAM or SIRIUS Galileo indices. They are very important nowadays. Doing only the anterior surface corneal topography is not enough. We have to do the complete corneal examination, including the posterior surface, the elevation maps, and rule out suspect keratoconus and posterior keratoconus. There is also a talk about nowadays corneal hysteresis, that is the biomechanics, but which is still debatable. In India, we are not following this strictly at most of the centers, but in certain countries, they are taking it very seriously, like in Argentina. So prefer, basically, this is the detail about how you do the topographic and tomographic analysis. PENTACAM, SIRIUS are the two main machines that are used. PENTACAM is only Schimflug imaging. SIRIUS is combined placido disc topography and anterior for the anterior and Schimflug images for the posterior cornea. So we use the 4 maps: refractive display, anterior elevation, posterior elevation, pachymetry map, and the sagittal curvature map. These 4 maps are very important. So look at the anterior elevation first, look at the posterior elevation, look at the pachymetry after that, and the thickness distribution. Off-center distribution of corneal thickness, I repeat, off-center distribution of corneal thickness is highly suspicious. So I look at the symmetry for both the eyes. If one eye is abnormal, usually the other eye is abnormal. So if one eye is abnormal, don't do the other eye if it looks like normal. So look for symmetry upper and lower half of the cornea, that is the symmetry index, and look at the curvature last, and analyze the indices and the software report. So basically the difference between elevation map of PENTACAM and SIRIUS is that reference surface, PENTACAM is best fit surface, whereas best fit sphere, sorry, whereas in SIRIUS it is the best fit toric sphere. So PENTACAM measures elevation from reference surface, so it is a true elevation, and recommended cutoff values are published. Whereas in SIRIUS there is no true, there is no true, and so there is no recommended cutoff for the true. PENTACAM and SIRIUS, the anterior elevation I have already mentioned. These are the 4 maps. In PENTACAM, we have a bad index display and D reading. If the D reading is in yellow or red, there are high chances of keratoconus. SIRIUS, we have symmetry index, SIF and SIB, KVF, KVB for highest point of ectasia, and BCF, BCVF and BCVB for front and back index. This is for evaluating the ectasia through analysis of comma and terfoil components of Zernike's decomposition. And then the software gives the report in SIRIUS. It gives the report whether it's normal, suspect keratoconus, keratoconus compatible, abnormal or treated, or myopic post-op. This is the bad graph and BAD graph, and then you can see the D value all are in red. So we should not operate such cases. This is the SIRIUS image, again image of keratoconus. I'll not go into the chart, but in SIRIUS there are indices which the software calculates according to this. For SIF, RMSF by A, that is the root mean square, and BCV index. Coming to occupational criteria, regulations as per armed forces, railways, we have to know relative contraindications to LASIK are contact supports, athletes, prefer to do PRK or smile in these patients, scuba divers, occupation dependent on quality of visual function. So detailed occupational history is very important when we are starting our refractive practice or we are into refractive practice. So based on contrast sensitivity and glare, there are certain people who drive in dim light, in fog, in night, in hills. So here we have to be very careful in seeing the mesopic pupil size, and we have to in detail discuss with the patient what he should expect. So long-term computer users prefer smile as dry eye induced is much less and recovery is fast. This slide has been covered by Professor Nepalia. So I'll just say that customized, optimized LASIK machines, astigmatism more than 1.5 diopters, we should do customized because cyclotorsion is important as astigmatism is high. And the root mean square value of higher order abrasions, if it is more than 0.3, we can prefer to do a customized LASIK. SMILE FDA approval is -1 to -12D for myopia, astigmatism -0.5 it was, I think it is now -3. C approval for MRSC is up to -11.5, myopia -10, and astigmatism -3. There is no hypermetropia treatment in SMILE yet. So pre-op assessment is same as LASIK. Here the SMILE percentage tissue altered, PTA we have to calculate as lenticule plus cap thickness, and up to 40% we can go here of the central corneal thickness. So ocular surface, mild dry eye can be done, as I have already mentioned, as subbasal nerve fiber regeneration is faster. Avoid difficult orbital anatomy, high astigmatism and uncooperative patients. Absolute contraindications are almost the same as of LASIK. Relative contraindications are also similar, but apart from that, mild treated ocular surface, tear film disorders, epithelial and basement membrane corneal dystrophies, significant wavefront abrasions, because till now we don't have any wavefront guided treatment in this. Contoura vision, the slide has been covered by Professor Nepali. I'll just like to add here that it has clear-cut superiority only in selected cases where there is definite irregularities on corneal topography which are reproducible at least 4 to 8 times per eye. Now coming to financials. When we talk about SMILE, Contoura vision and standard LASIK, we know that SMILE and Contoura vision may cost 3 to 5 times than normal LASIK. So are they for everyone? As per my talk, I think it is not for everyone, and my future speakers will be covering these topics in detail. So we need to be selective. Smart surface ablation has been covered. It is good for sports personnel, but disadvantages of PRK are not excluded here. LASIK XTRA has been covered. So follow strict case selection criteria. To conclude, I will say give time to the patient along with detailed options, best suited option for the given patient, and consent form, and let him or her decide. A good consent is very important in a LASIK surgery, otherwise there are chances that one lands into trouble for consumer cases. So be truthful to your patient, to yourself, and do not be market driven, thus end up in a happy patient and happy surgeon. Thank you.
Now I invite Dr. Arun Shetpal to share his views on surface ablation, advanced.
Good afternoon, everybody. I'll be talking about photorefractive keratectomy. Thank you, Dr. Neeraj, for giving me this opportunity. So basically, this LASIK, or the corneal laser refractive surgery, it started with PRK, went on to LASIK, and now it's again shifting back to PRK. So I'll let you know what are the factors why we are shifting back to the surface ablation. So basically, surface ablation covers 3 things: the PRK, the LASIK, and the transepithelial PRK. I'll be talking about these 3 things. So it was MacDonald who treated the first sighted human eye in 1988. But later on, the LASIK got popularized and the PRK went into hibernation. So surface ablation has returned as an alternative in specific indications such as a very low corrections and in thin corneas, and it's coming back again. So why we are coming back to PRK? So LASIK flaps were thought to be associated with increased post-operative higher order optical abrasions than PRK. The very cut of the flap used to induce higher order abrasions, and post-operative quality of vision was considered better with wavefront guided PRK than with the LASIK. However, recent data have suggested that both techniques are effective with equal vision and equal higher order abrasions at 6 months in post-operatively. So what are my indications of doing PRK? When would I would like to do PRK? So in the deep set eyes and narrow palpebral fissures, where it is very difficult to fit the suction rings, very difficult to insert the microkeratomes. So there I would prefer PRK. Thin corneas, of course, you are saving more tissue, you are saving more stroma. Steep and flat corneas, The microkeratomes won't work on steep corneas or the flat corneas. They would either cause improper cut or they may cause buttonholing. And to correct post-operative refractive corrections, such as refractive surprise after a cataract surgery or a residual refractive error after a laser vision correction, after PKs, after therapeutic keratoplasties. Low to moderate myopia or hypermetropia can be treated with PRK. My limit is up to 6 diopters. I have done up to 7 diopters also, and there are reports of being, people going up to -8 diopters. But standing here, I would recommend -6 diopters. Why? Because higher correction, higher ablation, more tissue ablated, there are more chances of haze, post-operative haze. Person who want to go in for contact sports such as football players or the martial arts players, people going in for defense services, I usually prefer doing PRK in them. And patients with epithelial basement membrane dystrophies and diseases, it's better to do a PRK than to make a flap. And of course, the retreatments I have talked about. Preoperative evaluation, I'll just skip this because this has already been covered. I would not like to repeat it. There's nothing which I would like to add on to this. Let's come down to the technique. Technique basically involves removal of the epithelium first, then reshaping of the cornea with the LASIK, with the laser, and then you apply the MMC to decrease the haze, and then you apply a BCL, a bandage contact lens. Now, basically, there are 3 ways, there are many ways, but I will be talking about 3 ways of removal of epithelium. You can do it with the help of an alcohol, you can do it manually, or you can do it with the help of a laser. That is, you can do a PTK and then a PRK. So, just a quick animation video of alcohol assisted. You mark the cornea 8 mm with the help of a trephine, centering it onto the cornea. Keep an alcohol well over it. Put 20% of alcohol. Keep it for 20 seconds to 30 seconds, whatever is appropriate for you. Usually 20 to 30 seconds are good enough. And then the epithelium comes out very, very smoothly and gives you a very smooth surface. And then you do your laser ablation. And after that, applying mitomycin C, and then you put bandage contact lens maybe for 4 to 5 days until your epithelium regenerates. Just the same thing, a video. So you put the alcohol well, put in 20% of alcohol. The video says 40 seconds, but for me 20 to 30 seconds are good enough. Before you remove the alcohol, make sure there's no alcohol left onto the cornea. If it spills over, it's going to cause a lot of irritation. If it spills over into the fornices, it's going to cause a lot of irritation to the patient. You wash it off very thoroughly, and then if you can appreciate that the epithelium comes off very smoothly. So it's basically you need to go from the periphery to towards the center. That's a good way of removing the epithelium. And then the laser is performed. This is not my video. I have taken it from the YouTube. And then you apply mitomycin C. You soak a sponge in mitomycin C and you can leave it there for 30 seconds, whatever is your nomogram. I'll just let you know about that. And then you wash it off with sufficient amount of BSS so that no mitomycin C is left. And then you apply a bandage contact lens. Manually, you can do it manually as well. It looks very untidy, but there's no chemical contact with the cornea. So first we do a SCC, that is a static cyclotorsion, and then we remove the epithelium manually with the help of a hockey stick knife. It would be a good idea to pre-mark about 8 millimeters before you start removing. Wash it off thoroughly, rinse the cornea. Then you need to dry the cornea before you start your laser, because 193 nanometer will not pass through a wet surface. You do your ablation. And then you apply mitomycin C. This is how I apply. I put a drop of mitomycin C and spread it all over the denuded area of the cornea. Leave it for 30 to 30 seconds, depending on the myopia corrected or depending on the ablation performed. And then you wash it off with sufficient amount of BSS, at least 20 to 30 ml, and then you apply your bandage contact lens. And then comes another thing which is known as transepithelial photorefractive keratectomy. So this is basically a surface procedure. PRK profile, you do a PRK profile for the refractive error correction, and then over that you do a PTK profile for epithelial removal. So basically it is a no-touch technique or the non-touch technique. So it is basically PRK plus PTK done in a single sitting without any break. The machine has, I have a Schwinn machine which does it in one go. It first does the PRK profile and then the PTK profile. So what you do is you first take the epithelial map, you do the epithelial mapping, you note down that it is about 55 microns in the center and about 60 to 65 centimeter in the periphery. So you go and feed these values here in the machine. You tell them that, okay, centrally I want 55 microns off, and in the periphery I want about 65 microns off. And then you feed in all the patient values. So this is what the machine is going to do. Machine is going to do a PRK profile followed by the epithelial profile. So it's first going to ablate the number, and then it is going to go 55 microns in the center and 65 microns in the periphery. Just a small animation video. Do I have the time?
To carry out no-touch or laser surface ablations. Trans-PRK treats refractive errors by superimposing an aspheric ablation profile with a defined epithelial thickness profile based on literature values and mean epithelial profiles of large-based populations. The trans-PRK is a transepithelial single-step treatment that avoids the eye coming into contact with any instrument. Trans-PRK is an advanced surface laser treatment because the epithelium is removed by the excimer laser more precisely and uniformly than with either manual or alcohol-assisted debridement. Trans-PRK applies an epithelial thickness profile that is thinner in the center than in the periphery. Because trans-PRK applies the laser beam directly over the epithelium, it acts as a smoothing agent for the residual stromal bed. Trans-PRK applied to regular corneas provides efficacious, safe, stable, and reliable results. Trans-PRK in combination with corneal wavefront is preferable for patients who need retreatment after radial keratotomy or corneal transplantation. Moreover, it can be used to treat haze, scarred corneal tissue, and keratoconus before corneal collagen cross-linking. Trans-PRK is a versatile approach. It's useful in all cases where a difficult epithelial flap is expected or when the epithelium covers corneal irregularities of the stromal tissue. To carry out,
and this is how it's done. I'll just quickly go through it. Once you do a cyclotorsion test, SCC, you map the iris, so it compensates for any cyclotorsion. You dry the corneal surface. That's all you need to do, and then the rest thing is being done by the laser. You fire the laser right over the epithelium. First it does the PRK profile. Without stopping in between, it goes to the PTK profile for removal of the epithelium. So it's very quick, it's very fast. And then of course you apply the mitomycin C as usual and wash it off and then apply the bandage contact lens. So basically, this has the advantage that it's a all laser, no touch technique, and it is a one-step procedure, no cut, no flap procedures, so no chances of any flap complications, and it's a minimally invasive procedure. Further, it allows for true customization, less chances of dry eyes, less chances of ectasia, and it's suitable for sport person, military personnel, etc. Now, PRK has its own disadvantages also. So, pain is one of the most important disadvantage or the drawback of PRK. Second was the haze, and then was the slow recovery and regression. So, all these things were taken care of. Pain was taken care of. Dr. Rohit Shetty and the Narayan Netralaya people, they have taught us by soaking your bandage contact lens for 20 minutes in AccuVeil, or for 20 minutes, if you soak your contact lens in AccuVeil and then you apply, this acts as a depot for on the cornea, and it reduces the pain significantly. We have been using this for quite some time, more than I think 2 years now, almost it's 2 years now. Corneal haze can be taken care with the help of mitomycin C. We usually use 0.02% of mitomycin C. We apply it for 30 seconds. If the ablation is less, if the tissue is being less ablated, we may reduce it to 20 seconds. And if I go beyond 3 diopters, suppose I'm going for up to 4 diopters, then I'll increase the contact time by 10 seconds. 10 seconds for each diopter beyond 3 diopters. So this is what I follow. Then there's a new substance which is known as SAHA, which is, I'll just quickly sum up. This slide has been provided by Dr. Rohit Shetty to me. I would like to acknowledge this slide from me. So this new substance, it causes less of reduction in the myofibroblast, and it's supposed to be better, but it's still in the animal testing phase. And it gives you an optimal outcome comparable to mitomycin C, but more number of myofibroblasts are saved, and it doesn't have any effect on the endothelium as well. Next is the smart pulse therapy. This SPT takes care of the slow recovery. The recovery is fast after this technology. We don't have time. Maybe if once we have a time, we'll talk about that. Conclusion, PRK is a reasonably safe procedure, effective and predictable technique. There are no flap-related complications, and it's a preferred technique in thin corneas and dystrophies. Thank you very much for your time.
Now we invite Dr. D.D. Verma to share his experience on LASIK.
Thank you very much, Dr. Neeraj, Khunger and team, to give me this opportunity. So we are running short of time, so I will confine myself to the topic, this scope of conventional LASIK in today's scenario. So I will skip few of the slides which are being already presented. So to correct the refractive error, we have certain options. In that's the superficial, that is PRK, LASEK and EPILASIK, and intrastrobal, that is LASIK and RELEX. So what are the advances in refractive procedure are FEMTO LASIK, SMILE and customized LASIK. So in the FEMTO is already, so now I will basically let you know what are the advantage of microcratom flap or their limitation and FEMTO flap. In mechanical flap, we cut from side to side with a globe pressure, while in FEMTO laser create an interface cut at predetermined depth. And the flap in mechanical is meniscus flap, while in FEMTO is a planar flaps. And flap thickness in mechanical microcratom flaps depend on the suction ring, thickness, corneal diameter and curvature, while in FEMTO is independent of any such parameters. Size and shape of the flap in mechanical make and D-shape flap, while in FEMTO is make a well-centered flap is created. Complication with the microkeratome are free flap, buttonhole are common, while in femto is a light sensitivity and photophobia common, but self-limiting. So what are the advantage of femto LASIK? Is a high predictability, more controlled flap depth, better contrast, centration and bloodless surgery, and the less flap related complication, as we see in a microkeratome, fast and painless. And the certain disadvantage or limitations are the longer suction time, more flap manipulation, expensive, cumbersome to shift patient from one room to another, difficult in lifting the flap after 6 months, and OBL interfere with the ablation subtime. So femtosecond laser flap is particularly beneficial in thin corneas, anatomical small eyes, deep-seated orbits, unusually steep or flat corneas. Femtosecond laser flap are more uniform in thickness than microkeratome flaps. So which one is better? Both the studies being done, they compare and they found that both the femto laser and the mechanical microkeratome for LASIK flap cutting are safe and effective to correct myopia with no statistically significant difference in post-op refractive status. SMILE will be covered by Dr. Virendra Agrawal. But still I will like to let you know the points and counter points of the SMILE and LASIK. You know, there are certain lenticule related complications, retained lenticular that were either not fully cut by laser or were told during extraction process, trapping a lenticule fragment within the interface. This fragment then has to be removed or the patient will have severe irregular astigmatism. And this is a comparison of the LASIK flap and the SMILE. When we take out the basically lenticule in the SMILE, those interface doesn't get line up. While in the LASIK, those interface get line up. So patient quality vision initially is better in comparison to SMILE. And in one more study, they found the post-operative contrast sensitivity was better in LASIK group. In first post-op week, quality of vision was reported to be worse with SMILE than LASIK. And again, there is a limitation of SMILE is a enhancement. No one has agreed on the way to perform a retreatment if primary procedure get an undesirable result. Option for enhancement are either surface ablation or convert SMILE to LASIK. In SMILE, correction of visual aberrations is not done. But in LASIK, recent technology option led to importance of wavefront-driven ablation in LASIK and their ability to reduce visual aberrations. So different type of laser ablation profiles are available in the market. It's a conventional LASIK that is based on Mundarlin's formula and the custom LASIK, and that we divide that in the wavefront guided ablation, wavefront optimized ablation, topo-guided ablation. In a conventional LASIK is based on simple spirocylinder correction based on the removal of tissue using Mundarlin's equation. Laser profile is based only on subjective and objective refraction. It doesn't take spherical aberration into account, so high order aberrations are not corrected. In Mundarlin's formula doesn't compensate for the loss of fluence in the periphery of the ablation zone because of the energy of laser pulse is spread out over a large area. Conventional LASIK induces spherical aberrations depend on the amount of attempted correction. Now we come to the customized LASIK. Conventional LASIK correct only lower order aberration, not higher order aberration. So these attempts to customize treatment by reducing optical aberration by total wavefront error of patient in wavefront guided ablation. The wavefront aberration measure and wave distortion which is then inserted into computer and linked to the examined laser machine. Advantage of this, the higher order aberrations are treated with vision quality is better, but it ablates deeper stromal tissue than conventional laser. So benefits are patient existing higher order aberrations are measured and treated, but side limitations, new higher order aberrations are induced if there is a less than perfect alignment of the ablation pattern on cornea, new higher order aberration if less than perfect eye tracking system. When LASIK flap is created, aberrations are induced which are not accounted in wavefront. The size of wavefront is determined by size of the entrance pupil. Topo-guided, this is particularly useful in irregularities of corneal surface, scarring, surgically induced irregular astigmatism where the wavefront treatment are not very useful. This is already. So, this topo-guided better than conventional as a pre-existing high order aberrations are corrected tends to maintain the prolate shape of cornea. But treatment is independent of overall spherical aberration of the eye, so the quality of vision may not be as good as expected theoretically. When LASIK flap is created, aberrations are induced which is not accounted. So these are the different, customized lasers are available in the market with their aberrometers. Now we come to the comparison of the conventional and the custom LASIK. These are the studies done and with the NIDEC EC540, and they found that night vision is better with the topo-guided CAT, LASIK. And again, they did the study with the LADAR Vision 4000 with the wavefront guided LASIK, and they found it's a better than LADAR Vision 400. And one more study, they found the significant better vision performance is got is a VG LASIK group compared with the LASIK group 1 year after surgery.
Can we sum up, Dr. Didi?
Yes. So I conclude, though customized LASIK is beneficial in terms of quality vision, but in developing countries like India, we cannot ignore the cost of factor. Surgeon decisions should not be market driven. Therefore, many factors are to be considered prior to monopolizing custom LASIK over the conventional LASIK. If you permit me, I would like to show the video of 1 minute. So basically, we should not use any cloth because fibers may go and settle in the interface of the LASIK. So we clean the eye with a free flow of BSS, and we place the ring, and suction is created. I don't use any applanation tonometer, but with fingertip I assess the pressure, and the keratom is locked. Flap is raised. And eye tracker is locked, and then we fire the laser. So here I want to show how to clean this stromal face. I do not place the flap early, and I clean the interface with the merosil with a free flow that is under positive hydro pressure. So there is no meibomian secretion or any debris are settled in the interface. I simply replace my flap on the cornea and iron the flap. Thank you very much.
Upon Dr. Virender Agarwal to talk on smile. Does smile always give smile on patient's face? Dr. Virender Agarwal, as you all are aware, is one of the pioneer in refractive surgeries in India, and I think the pioneer in smile.
Thank you, Dr. Khunger, for giving me this opportunity to speak on smile in your IC. And as your question is asked, that does the smile gives always the smile? Yes, definitely. If you have taken the case into a proper selection manner, then it is there in all cases. So this is the lady I am saying, and this can be the problem when you don't take care of the patient and you do surgeries which are not required. So the first thing in refractive surgery is that always do surgery only when it is clearly indicated and safe. So if you take care of this safety, then you will all smile. Just to show the smile procedure in the beginning, because we are running short of time, so I would like to see that the smile surgery is something different than the laser, LASIK or PRK, in which we are not creating the flap, but at the same time we are not creating the loss of epithelium from the surface. So it is being done a lenticule formation inside the cornea itself. We are doing the posterior lenticule surface formation, then the side cut, and now it is the anterior surface formation of the lenticule, and we'll have a small cut. Now we are doing this 2 millimeter cut. This is a separation of the lenticule anterior and posterior surface, then the blunt dissection with the spatula, and after this spatula dissection, the lenticule can be removed with the help of forceps or hydro dissection, and just by hydro, the procedure comes out. And during the surgery itself, we have a slit lamp attached to the machine, so we can do a slit lamp microscopy to see any debris or something is left over. Now the question still remains that does a smile bring the smile? The reason of bringing a smile in smile is the patient is very comfortable during the surgery and post-surgery because there is no issues with the epithelium, one. Second thing, during surgery itself, patient is not getting vision knocked off because the applied vacuum with this concave system of the application is this, that the patient's vision is maintained throughout the procedure. And especially when we talk about the biomechanics, we all know the anterostroma is having the strongest layer, and this strongest layer is having an area where we are avoiding doing any kind of procedure in smile, but in PRK we are removing this, and in LASIK we are creating flap of this strongest layer, and because of these preventions, the smile is giving better biomechanics. There are many studies, though still in doubtful because the measurement system of biomechanics is not very repeatable. Better accuracy is there, and I will just like to show you a special example in which you can see that when you do a LASIK or laser, it will happen that decentration is common or can be there. Not common, I will say, it can be there, but in smile it is not there. Corneal nerves are preserved, and because of this, the dry eye is less. And this is the important point where you can see the patient's wow factor or comfort for the surgery or after surgery is very high. And when we talk about centration, this is what I was talking about. The centration is there because we are docking the eye and we are holding the eye during the treatment, so the centration is very perfect, as well as the optical zone used and applied is the same. And this can be sometime a decentered LASIK, which is not there with the smile. So that is another advantage over here. And when we talk about the canal sensation, because of the nerve preservation, we are having advantage. And as mentioned, the femto lasers causes less of high order ablation, and this I will show you by another means, that in some patient we have done smile as well as the ICL in the other eye when the cornea was not touched. This is the patient, the other eye, the first eye, right eye is having minus around 8 diopter of spherical equivalent refractive error, the other eye was minus 3 with 2 cylinder. And we did ICL in the right eye, we did the smile in the left eye, and you can see the quality of vision in the left eye and right eye. And the right eye quality of vision is much more worse than the left eye. So the advantage of doing a smile over these patients, it does not mean that the smile cannot give a better quality of vision. And just to conclude, there is no risk of the flap related complications. As Dr. DD has said that sometimes there are relations with the lenticule, but touch wood, over 3,000 eyes of my experience, we never had a problem with the lenticule because it was always having a good dissection, and we were able to remove incomplete. However, few patients, around 10, we had a cap cut while doing dissection. In initial phases, it was probably because of learning phase, and the energy settings were higher. Now we have reduced the energy setting in smile, and that has bring us the wow factor. And the basic advantage of having a biomechanical stability, less induced abrasions, and there is no flap. This is being very useful for many of the patients, and particularly for the persons who are having contact sports or those who are at the risk for having complications with the flap. Thank you very much, and I would like to just give you a take-home message you have to choose the the procedure according to the condition. I'm not saying to do a smile in all patients, but any patient who is affordable, I will prefer to do a smile, as because of my experience of 20 years, I found the complications are least with a smile, and this is having a definite advantage that because there is no flap, the corneal nerves are protected, and that is having a natural help in recovery also. And complaint of glare and halos is not there because we are cutting actual optical zone, and when we know that we do 6 mm optical zone, that is good enough for majority of the patients. So that is my request and to you to take home message that always choose the best procedure according to the condition, and smile is not having any negatives other than the other procedures. Definitely there are some limitations. The smile cuts slightly more than normal LASIK patients, and when we do a surface ablation with my machine with MEL 90, the profile is such low that we have a tissue saving in smile in LASIK and surface ablation, but in smile we are cutting slightly more than these procedures. Thank you very much. And if the time permits, then we can show you a difficult situations in which that the video can be just, how much time is left? Session is over time? 125, okay, thank you, we'll finish. Otherwise, I can show you that whenever there is a complication, like if we have a lost suction in the LASIK in between the procedure, then the flap is into a difficult condition to manage. But in smile, if the suction is lost, you can redock and immediately you can do a completion of the treatment. Thank you very much.
Thank you, Dr. Virender. Just to summarize, I'll be talking on tailored approach for an individual patient, as we have very less time left. So, while following strict patient selection criteria as discussed, large quantity of patients do equally well with conventional LASIK. That is what we have summarized. So depending on certain occupations and eye conditions, specific technique may give better results in an individual patient. Computer operators prefer PRK or smile as it causes less of dry eye and faster nerve healing. Relative contraindications to LASIK, contact sport, athletes, professional scuba divers. So PRK or smile, we can prefer that among this. And smile is definitely better, as we have already all have heard from Dr. Virender Agarwal, if the patient can afford. So occupation dependent on quality of visual functions based on contrast sensitivity and glares. So drivers indulging in dim light and fog driving, we can go ahead with a topo-guided treatment. Mild dry eyes, smile is the best choice. Mesopic pupil nearing 7 mm eye, smile is an option. Avoid other keratorefractive procedures as induced higher order abrasions are much less in smile. Thank you. Any questions from the audience? We can take fast questions, 1-2 minutes.
At the same time, we invite the co-instructors and instructors for the next course to join us on the dais. And if any questions are there, we will be happy to answer.